You may know them by brand names such as Valium, Xanax, and Ativan. More broadly, they are a class of tranquilizers referred to as benzodiazepines, or simply benzos. They are prescribed primarily as an anti-anxiety medication. However, there are signs that's no longer all they're being used for, and even in that context, there may be more misuse than there ought to be. With us now for more, in Queens, New York, via Skype, Roger McIntyre, professor of psychiatry and pharmacology at the University of Toronto and head of the Mood Disorders Psychopharmacology Unit at the University Health Network. And back here in our studio, Tamina Eapen, lecturer at the University of Toronto and a psychiatrist also with CAMH, the Centre for Addiction and Mental Health, Alexander Caldarella, family and addictions physician at the University of Toronto and St. Michael's Hospital, and Yarissa Herman, clinical psychologist with West End Psychological Services and CAMH, the Centre for Addiction and Mental Health, who are well represented on this program today. Good to have everybody on here in this. Is this your first time on TV?
It is.
We are delighted that you have decided to have it with us. Thank you very much. Roger McIntyre, good to have you on again. It is certainly not your first time on this program, and we're glad to see you and happy you could make some time for us in New York. Let's put this fact file up, everybody, just to get a little background in place. Shelton, if you would, bring the graphic up, and here we go. A report from 2017 showed that 10% of the general population took a benzo at some point in the past year. Women are almost twice as likely to be prescribed these drugs as men are. And 51% of the fatal opioid overdoses in this province involved benzos. So let's find out more, first of all, about what they actually are. Roger, you want to get us started? What are benzos and what do they do?
Sure, Steve, you're right. You had mentioned tranquilizers. These are referred to colloquially as minor tranquilizers. They were first isolated back in 1955. They've been first approved in the early 60s for the treatment of really a broad set of purposes. These purposes include anxiety, insomnia, alcohol withdrawal, and seizure disorders. And the use of these medications over the last 4 to 6 decades has waxed and waned, peaking in the mid-70s, coming down slightly in the 80s and 90s, then only then to be increasing. In fact, on the last 15 years, we've seen a significant increase. You cited the percentage, the trajectory is going up and up of people who are being prescribed these medicines. Secondly, the number of people who are receiving repeat prescriptions is going up. And thirdly, which is very concerning, is the number of people being prescribed a benzodiazepine with another controlled substance, such as opioids, has also been increasing. So taken together, this, what we call pharmacoepidemiology, has been very concerning to a lot of us.
Tamina, how addictive are benzos?
They're very addictive. We now know that dopamine is increased in the brain after the anxiolytic properties of benzodiazepines can take place. And so just like any addictive medication, like opioids, like cannabis, like alcohol, we're discovering that benzodiazepines are very sticky in our brains. And it's hard. I use the word sticky.
That's
yeah.
okay.
Yeah.
That doesn't sound like a pharmacological term.
It's pretty technical. Yeah. No, but it's a good way to think about it. Certain molecules are more sticky than others, and certainly benzodiazepines are right up there.
Do you think they're overprescribed?
Yeah, I think one of the things is that we're seeing a lot of people who previously have been prescribed, and a lot of people are struggling to either take people off the medication or to find ways to find alternate treatments. So they may be overprescribed in a certain way, but I think they're continuing to be prescribed in another way because people just aren't comfortable removing them.
Do you think they're overprescribed?
Yes, and also I think that it's important to recognize that there's alternative possibilities to treat anxiety, such as psychotherapy, and potentially with the addition of psychotherapy plus the prescription of benzos, we see quite good outcomes. And we also see that when people come off benzos, if they've received something like CBT, they are less likely to relapse. Oh, cognitive behavioral therapy, apologies.
Yes, this is an acronym-free zone.
Yes, they're less likely to relapse into anxiety. And so I think that they are overprescribed, and I think it's important to recognize that there's some alternatives.
I guess it would be easy just to say we're going to blame all the doctors for overprescribing, but I presume patients also put a lot of pressure on doctors to get these pills because they've heard so much about them.
For sure, and they're effective, and they're easily accessible, and they're quick.
And they're quick, meaning what? They work fast?
They work fast, whereas something like psychotherapy can take a lot longer, and it can be a lot more work.
Roger, who gets to prescribe these medications?
Well, all healthcare providers like prescribing them. There's certainly been a wide use of these medications and specialty services appropriately in some settings like psychiatry and also in neurology settings as two examples. But what we've observed, and there's been a recent report here from the United States, is in primary care, there's been a steady increase in the prescription of benzodiazepines during the last 15 to 20 years. And as I was saying earlier, this is coinciding with a quadrupling of co-prescription with opioids. Obviously, this is very concerning because one of the stats that you had, Steve, at the start was the toxicity in terms of overdose. And we know that when benzodiazepines are combined with opioids, it increases the toxicity of these medicines and overdose. So very concerning. I agree with my colleagues that are with you in studio that I do think that there is, in fact, an overprescription. And more specifically, I do not think, in fact, there's been the appropriate assignment of treatment to patients. I've spent the last 15, 20 years, it seems almost as a full-time job, trying to take people off these medicines. People take them for a variety of reasons. I enumerated some of the indications, but one of the primary reasons they take them is because they work, and they work very quickly. But that being said, is that the short-term gain these medications offer is often, if you will, overshadowed by the long-term the liability. And I agree with the comment about psychotherapy, and I think that there are clearly lots of evidence now to suggest or indicate that CBT, cognitive behavioral therapy, is the best way to treat anxiety in the longer term. The issue we get into is real world. And the real world is most busy primary care providers say, I don't have a psychotherapist next door. I don't have the ability to get patients on the internet and coach them through this. They lack the motivation. So some of these structural issues, unfortunately, end up conspiring against us, leading to benzodiazepine overprescription.
All of that having been said, Alexander, would a way to reduce the proliferation of writing scripts for this medication be to prevent family docs from doing it anymore? Make it more restrictive.
Well, I think you can't look to just blame family docs. I mean, like we were saying, a lot of them are continuing old prescriptions, and we don't want necessarily people ripped off these medications. That comes with a lot of harm, too. The other part is people really want to help the people in front of them. And I think, as was just mentioned, we have to provide more services and more help for family physicians to be able to do things. And I think the last part is, it's not only the prescribing, it's the way they're prescribed. So the doses, the high doses, but also the fact that people are going home with months of prescription at a time, which means that a lot of it can get either diverted to the street or be taken inappropriately. So even just training people to prescribe it in a safer way might be a way that we can help curb some of these overdoses that are happening.
So would you put in a new regulation that said, sorry, you're not going to be able to prescribe 6 months worth of benzos anymore?
I'm not sure that, I guess I would. I mean, it's hard for me to suggest a regulation of that sort, but it sounds like that would make sense. I think an additional option would be to increase the amount of available psychotherapy within family physician offices.
We're at a moment right now where we're trying to spend less on healthcare, not more. So what are the odds on that happening?
I'm not sure. You know, I know that over 80% or up to 80% of Canadians rely on their family physician to meet their mental health needs. And family physicians are generally trained within a medical model. And some do receive additional training in psychotherapy. So there are some options for OHIP-covered psychotherapy, but the wait lists are quite long.
Indeed. Tamina, I want you to help us understand why, as we suggested in the intro, women are twice as likely as men to be prescribed these medications.
I suspect it's because we're more articulate and generally more in touch with our feelings. We tend to be help-seeking. We make connections with healthcare providers, and there's less stigma around women expressing distress.
The less generous interpretation might be that more male doctors think more women ought to just take a pill and call me tomorrow morning and see how it goes.
That's certainly less generous. And there is a bias towards, prescribing an antidote for distress. And I suspect we are medicalizing a lot of stressful feelings in addition to trying to address them.
So you acknowledged it was a less generous interpretation.
I do acknowledge.
But am I wrong in suggesting that?
We also have a lot of female physicians now. More than half of med school classes are female. And so I suspect that we just expect women to, A, ask for help, and B, are more likely to follow through with the care we suggest.
I'd be curious, Alexander, if anybody had done a study on whether female physicians and male physicians prescribe these medications in the same ratios to their male versus female patients. Does anybody know anything about that?
I'm not sure. That's not something I've heard of before. I mean, I think if you look historically, there was a lot of advertising specifically at women for Valium. And like we're saying, a lot of this might be new prescribing, but some of it might just be people who've been on this for 30 years to help them sleep. So maybe they're still reaping some of that benefit from the old, maybe improper advertising.
Roger, I want to get a better understanding, because I think the Rolling Stones in the 1960s had a song called Mother's Little Helper, and the idea was take a Valium and you'll feel better. 10% of the population is taking it every year. How did it become so normal to take these drugs?
Well, for a variety of reasons, and you're right, that goes way back to the 70s. And I was mentioning at the top, back in 1977, benzodiazepines were the most prescribed medications in the world. They were very popular. The second part of this is that the World Health Organization has what they call a model list of essential medicines. This is a list of medicines that, according to the World Health Organization, are essential for the safety and the health of a general population. It should be stated that benzodiazepines, a few of them which are actually on that list. So these are medications that are not only regulatorily approved, but also, in fact, have been endorsed by credible organizations for appropriate usage. And of course, this also fosters the use of these medications. What's so interesting to me, Steve, from a context around the benzodiazepine use and the uptick in the last 10 years, is that this is not necessarily being fostered by the pharmaceutical industry. The pharmaceutical industry promotes their medication. That leads to an increase in the prescription of these medicines. That's a whole separate conversation. What's interesting is that benzodiazepines are generic. That is, they're not being actively promoted at promotional programs with prescribers like physicians, physician assistants, nurse practitioners, and more recently pharmacists. And we're seeing this uptick. So I think that therefore, we need a different kind of conceptualization or additional factors to consider. And more recently, we've been wondering about the epidemic globally of the loneliness scenario that's unfolding. And as a psychiatrist, I see this. As an academic and as a scientist, we write on this in terms of the global epidemic of loneliness is generating, really, if you will, the foundation, the edifice for not only depressive syndromes, anxiety syndromes, but also shortened lifespan for many people in the general population. So we have a more distressed society, if you will.
Well, Yarissa, you don't have to go back to the 60s or 70s to find music that promotes the use of these medications. I know Drake has a song out in which he talks about needing to take a Xan to get through a flight. Xanax, I presume he's talking about. Do you think it's a problem that the culture seems to be kind of promoting normalized, if I can use that word, use of these medications?
I do, and I see young people who are taking Xans to get high, simply.
At what age?
17, 18.
I presume you don't think that's a great idea.
I don't.
What's a better alternative?
A better alternative
For a
is
16 or 17-year-old that want, how do you tell them this is a really dumb idea?
Well, we try to look at, as was stated, the short-term gains and the long-term consequences so that we can build some internal motivation for change, having someone realize that maybe over the long term this isn't the best thing for me to do, and learning why they're using it, what the purpose of their use is, the function of their use, so that we can target that and provide other strategies to have fun or other strategies to cope with anxiety so that they're not relying on Xanax or whatever it may be.
How does a 16-year-old teenager get a prescription filled for Xanax?
I'm
not sure that that's always legally prescribed.
Aha, there we go.
Yes.
Steve, can I comment to that point?
Please, go ahead, Roger, yes.
Yeah, because you asked, is it safe and effective, or you alluded to, is it safe and effective to give Xanax to a 16-year-old? I certainly don't believe it is. I think it's highly inappropriate. But here's what I'm concerned about, is that we have, in fact, the widespread marketing of recreational marijuana in Canada at the current time, and it's being used for many purposes, including but not limited to anxiety and sleep. And certainly in a 16-year-old, I've got significant concerns about the consumption and the increased utilization of marijuana from the point of view of doubling the risk of psychosis in people at risk, and only, in fact, worsening some of the underlying reasons people feel anxious, like, for example, depression. So we're talking about benzodiazepines. I think we have agreement on the panel that we're all very much reacting with disquiet to what we're seeing. But I also would like to, in fact, call out the elephant in the room that we're seeing a massive uptick in terms of recreational marijuana. People thinking this is a safer alternative to manage their anxiety, and that is clearly not true.
Do you agree that there are precious few circumstances under which a 16-year-old ought to be prescribed for a Xanax or Ativan, that kind of thing?
Yeah, I can only think of one, and that's if he's in withdrawal from a benzodiazepine. or alcohol.
Talk to me about that. What's that like, withdrawal from these kinds of things?
It's terrible having never been in that withdrawal. I can't say from personal experience, but really we have an entirely physiological response where our heart doesn't know what to do, our lungs don't know what to do, and we go into a panic zone. And it can lead to death when the benzodiazepine receptors are not able to mitigate the withdrawal more safely with benzodiazepines or alcohol.
We have this stereotypical image, I suspect, in our heads of somebody getting the DTs and shaking in the corner and hallucinating. Right. Would you have that kind of experience trying to get off benzos?
That would be the extreme case of withdrawal from benzodiazepines or alcohol. More moderate case would be a sense of anxiety, would also be a very rapid heart rate, increased blood pressure, decreased or increased respiratory rates.
Have you seen patients try to get off these things with these kinds of side effects?
Of course, it's something we see in the hospital all the time. And one of the problems is alcohol, you start to go into withdrawal quite quickly. But benzodiazepines can take weeks before you show any signs. So that's what happens when people cut back people's medication, and then those people start to manifest more anxiety a couple weeks later, and they say, I can't survive without this. When we take somebody off their benzodiazepines, it can often take 1 to 2 years just to take them off, because you have to do it that slowly to be successful. And there's a lot of hand-holding that has to happen.
When a patient says to you, I can't live without these things, you can't wean me off them, what do you do?
Well, we have a conversation. I think many people actually who've been taking it, especially the ones who've been taking it for a long time, don't understand the risks. They don't understand that it's associated with more mortality. They also don't understand that if they're taking it to sleep, it's impacting them the next morning. It's impacting their judgment, their ability to think. And when you really lay these things out, they say, I don't want it. And when you say, I'm going to be there to make sure that you're not going to feel sick as we do this, we're going to do it slowly, most people are fine to do it. And that's where it's kind of, the patient shouldn't be seen as the enemy. The family physician shouldn't be seen as the enemy. It's just about more tools and more tips to be able to do that.
Let's, Yarissa, put this in some kind of perspective, because we don't want to give people the impression that everybody taking these things is having these wild hallucinogenic nightmares and so on. What percentage of your patients, for example, or the people that you deal with in your profession, would be in a problematic place with these drugs, and what percentage are taking them just fine according to prescription, and it's going tickety-boo, as it were?
Well, a lot of people that I see, particularly in my private practice, come to me prior to taking these medications because they already want to learn their own internal coping strategies. For those that I see that are taking them as prescribed, I often work with doctors to help them reduce safely and under medical supervision, while also increasing their internal coping strategies by using something like cognitive behavioral therapy.
Roger, what would be your sense of the percentage of people who are actually taking these things fine and as prescribed versus those who are either abusing them or really ought not to be on them at all?
Before I just address that, Steve, I just wanted to clarify something you began to reframe for us, and that is that as a class, we know that benzodiazepines have a liability to abuse. But that liability to abuse is actually very different across the different types of benzodiazepines. Some are more shorter acting, some are longer acting, and the shorter acting agents, for a host of reasons, are more liable to abuse. Moreover, in the general population, there's clearly an abuse liability, but that abuse liability is disproportionately higher in subpopulations, people who abuse other drugs and alcohol. So I want to make it sure it's very clear we're not conflating physiologic dependence from abuse. In other words, when you take any benzodiazepine for a period of time, your body adapts to it, and then when you no longer have it, there's a physiologic withdrawal. That's not the same thing as abuse. Abuse is often used, this is kind of language that's interchangeable, not precise with addiction, where people are using it for non-therapeutic reasons. In my clinical experience, more than 75 to 80% of patients prescribed benzodiazepines in my clinic are taking them appropriately. Now, I say that insofar as they're not abusing it, they're not misusing it, they're not diverting it, and it's not a gateway activity. But that being said, what I counsel patients is I'd like you to switch over to other strategies, and we can organize psychotherapy for you, alternative pharmacotherapies with a better safety profile. We aim for that. And I should also underscore that in the long term, there are significant implications in terms of cognitive function reduction, and as well as some people believe there's a concern about, a higher risk of dementia. This is why I also think that people over the age of 45 or 50 should not be prescribed these medicines routinely. There's a criteria list we call the Beers criteria, which is a set of medications we don't like to give to the elderly for this very reason, because benzodiazepines cause cognitive impairment and they're on that list. They shouldn't be prescribed. So I think that, like many things in life, we like to talk about it as just one large topic, but there are subpopulations that I think deserve more nuanced conversation.
And I appreciate that clarification very much. That's very important to put on the record. Let me, speaking of putting on the record, share a number with all of you here. Abacus does surveys, Abacus data. And last year, they discovered in one of their surveys that 41% of Canadians, 41%, say they struggle with anxiety. Now, when you hear that number, what do you think?
It makes me feel sad.
Now, are you trying to be funny there or what?
No, I mean it's a shame. That's a high number. And I think that, you know, from a very young time in most of our lives, we're taught not to feel these sorts of emotions, or that these sorts of emotions are bad in some way. You know, as a society, we want to hold on to kind of those happy emotions. We want to push away the bad emotions, the sadness and anxiety. And so we're not taught to sit with our anxiety, to be with our anxiety. Anxiety can be a really healthy thing. You know, anxiety can let me know that I care about something, or it can motivate me to study for an exam. It's not always bad. When we avoid it, when we push it away, it becomes scary and bad and ugly. And so that number, I think, represents some of our beliefs around the function of anxiety.
Well, let me pick up on the exam. If you're a student and you have an exam coming up and you know that a significant amount of your future career depends on you passing or acing this exam, are benzos, so you know this is going to be a short-term issue, right? I got to pass this exam next week. Would it be a wise idea to get prescribed for benzos under those circumstances?
I would like to meet a physician who says it is a wise idea. I can't imagine that that could be classified as wise at all.
Okay.
And as Dr. McIntyre pointed out, we're now seeing a lot more cognitive impairment, not just with long-term use of benzodiazepines, but even with shorter use, depending on the potency of the agent and the frequency with which they're used. So it would be completely contradictory to improving your study acumen.
Okay, let me give you another scenario. It is not unusual for some people to come home after a long day's work and pour themselves a scotch and put their feet up and just, because that, what's the expression? Kind of takes the edge off of the day.
Right.
Should you do that with benzos?
You should not do that with benzos at all, unless you have a diagnosed anxiety disorder and you're on a treatment program and you're under the skillful guidance of a physician such as Dr. McIntyre, and you're lucky enough to have a psychologist like Dr. Herman help you with coping skills, then I suppose there would be a schedule that's possible wherein you have a pseudo-scotch in the form of a benzo.
A pseudo-scotch. You want to weigh in on that?
Well, yeah, I mean, I think that obviously we're all in agreement that prescribing those situations would be dangerous, but what we're also seeing is that those are the kinds of people that might go out and buy one on the street or buy one of those diverted pills. And what we're seeing in this province right now is a toxic drug supply. So what's happened is it used to be maybe somebody would take some Xanax and they'd get dependent or they'd develop a problem. Now it might have some fentanyl in it, might have some opioids. There's just this mixing of drugs whereby anything that's bought on the street can't be trusted. So when you're saying a lot of people are dying of benzodiazepines in their system, I'm not sure many of those people even knew they were taking benzodiazepines. And I think that the toxic drug supply on the street right now is just something that's part of that. So that student who goes, buys a Xanax because he wants to feel better, what if that's not really Xanax? What if it's something far more potent and then they don't wake up the next day?
Right.
And I think that's a real reality of what we're seeing too.
Let me give another scenario. Roger, comment in on this one. Would you ever, now that marijuana is legal in Canada, and again, somebody's maybe trying to take the edge off from a tough day, or they're anxious about some big event in their life coming up, would you ever say to them, if they asked you for a Valium, I'm not going to give you a Valium, just go smoke a joint?
No, I would never tell a patient go smoke a joint. I strongly believe, and I've got tremendous concerns as an advocate of this space and as a dedicated academic in this space about what's happening in terms of recreational weed consumption in Canada, the United States, and elsewhere. There is no question that recreational weed is associated with brain toxicity in terms of doubling the risk of psychosis. I mentioned that earlier in young people at risk. It is highly associated with profound amotivational states. Someone talked about dopamine dysregulation earlier. Cannabis can adversely affect dopamine, which is the motivational signal in the brain. And as well, it can profoundly increase cognitive impairment. Now, I think in fairness, recreational weed is a separate conversation. That's where I think any legitimate clinician has concerns. I think from an academic perspective, there's some very interesting questions that are arising. For example, in the academic space, There's questions, for example, can purified cannabidiol be brain therapeutic? Can it mitigate anxiety? Can it mitigate depression, improve psychosis, and improve cognition and sleep? And the answer is we think that it might, but we need more research. And we certainly would not recommend it. It's not for prime time. So I see it as promissory, but not for prime time. But recreational marijuana, I would not recommend that. And my patients usually tell me thanks, but no thanks. I'm going to keep smoking it.
Go ahead, Alex.
Well, one of the things too, and I think this is very important, is maybe people use it occasionally is one situation, but for people who are using every day, one of the withdrawal symptoms of marijuana or cannabis is anxiety. So sometimes people feel anxiety when they stop it, and then they take it again and they feel better, and they feel like they're treating their anxiety, but really they're just treating their withdrawal. So, yeah.
You were the one who mentioned dopamine earlier. So are there ever any circumstances under which you would say, I'm not going to give you an Ativan, go smoke a joint?
No, how about I'm not going to give you an Ativan, go for a run.
Go for a run.
Yeah.
Exercise better.
Do something else. Have a conversation. Feel some social connection. I think everything we do fundamentally is modulating our brain chemistry in some way. And so the idea that there's always an exogenous or external solution to the internal problems is a bit of an issue, and we need to work on self-regulation, not just so literally as in a cognitive or behavioral framework, but also just in terms of what are some behaviors we can do on our own, including deep breathing, maybe having a glass of water, just taking a step back and thinking. And everything we're doing, just as now the way I'm speaking is impacting your neurochemistry, has an impact, and we can even talk to ourselves to mitigate some of our own stress.
How are you impacting first of all, I shouldn't use impacting as a verb. How are you having an impact on my neurochemistry right now in the way you are speaking?
Well, what is the impact?
Well, I'm listening to what you're saying.
Yes.
But I'm unaware of what's going on neurochemically in my head right now as I try to process the information you're saying.
That's fair. It would be weird if you were so aware of the neurochemical processes, but interesting also. I think you know how it makes you feel. I think you know what you like about it, what you don't like about it, whether you think I'm speaking too quickly, maybe you think I'm nervous. But there is something that's happening and that's fundamentally altering the molecules in your brain. And what we're trying to do with medications and what we try to do with therapy is to adjust that in a more directed and governed manner.
That was, your patients are very lucky, I guess. That was a very good analysis of what's happening right now in my head.
Thank you.
Yeah. You don't make me nervous for what it's worth.
Am I speaking too quickly?
No, you're not speaking too quickly. You're informing me, which I love. I think it's great. Yeah. How about, can you weigh in on this, the whole marijuana versus Xanax debate?
Yes, I would never recommend that somebody smoke recreational marijuana, particularly before the age of 25 when our brains are developing. And similarly, I would state, so for centuries, people have been using substances to explore our consciousness. And I think there's a fine line between using something to relax at the end of the day or to have fun, as opposed to needing it to function. Like if I need a benzo to get to work, if I need alcohol to, fall asleep, that's where I think a problem lies. And I do think that line is quite fine in terms of, recreational, self-exploratory, consciousness-building work and dependency or the necessity in order to function.
I don't think you're speaking too quickly either.
Thank
I'm
you.
also very informed by what you're saying. I just, in the interest of equal time here. Roger, comment in on this. Is taking substances to help you cope with life's challenges causing us long-term problems in terms of our ability to actually cope with life's challenges?
Well, I think that the answer is informed by really what's the underlying framework or what's the overarching framework of why we think that people are resorting to these types of behaviors. Now, we're talking about benzodiazepines. We've used Xanax as an example. We've talked about marijuana. Let's not forget about food. I mean, food is a drug, and we're seeing an obesity epidemic that's occurring. And so there's a larger question. Why are we as humans so inclined to reach for exogenous substances that provide either a temporary reward and or temporary anxiety reduction? And I think this is a very interesting, a process to walk through what's actually happening. And clearly, it would be impossible to have a comprehensive model of this without bringing in social determinants. In other words, what's happening in society at large? And, we hear statistics, for example, wage stagnation. We hear about income inequality. We hear about Canadians and Americans who are house poor and in debt, particularly student debt. We hear about, sort of this dichotomy between the haves and have-nots. This aspect certainly is playing some role clearly in the general distress that people are experiencing. We also, in fact, have to also wonder to what extent this is causing and/or is a consequence of what I referred to earlier, what Vivek Murthy, who was the Surgeon General of the United States a few years ago, called the loneliness epidemic. And so rather than prescribe, I agree. I think that psychosocial treatments are the bedrock of treating some of these problems, but it begins with a very careful formulation as to why the person's experiencing this inability to reduce their anxiety and or feel a sense of fulfillment and reward. And for different people, there's different answers, and that will, of course, guide what you're going to recommend for them. We very much believe that some of the basic everyone knows in terms of good sleep, good exercise, and good social engagement, as well as a good diet. These are all key factors. But I think that there's a larger analysis here, which I think is really interesting, not just from the point of view of conceptualizing it, but how can we prevent and really reduce some of this distress that's occurring in the general population? People like to point their finger at social media. I think social media maybe cause consequence and have no involvement in this process of the loneliness epidemic and some of the distress, but certainly it's been caught up into this conversation as well.
Well, just for argument's sake, Alexander, let me go to you with this, and we've got just about a minute and change left to tackle it. You know, if people watching this had a headache, they wouldn't think twice about taking an aspirin. If they had a stomach ache, they wouldn't think twice about taking something that would help relieve the pain in their stomach. And we've certainly spent a lot of time trying to convince people that they shouldn't ignore their mental health problems, and therefore they may logically infer that if they've got a mental health issue, they should take something for that too. Have we gone too far in that?
Well, everything's a balance, right? And you know what? For both physicians and patients, you want to see them get better. But we've seen really creative prescriptions people get handed. People now get handed in certain countries prescriptions to go to an art gallery or a prescription to go get exercise. So you're leaving the doctor's office with something physical in your hand or a ticket, but at the same time, something that might help your mental health in the long term much more than a pill.
Gotcha. I want to thank everybody for coming on to TVO tonight and helping us out with this. This was really interesting. Roger McIntyre, the head of psychiatry and pharmacology at the U of T, thanks for being there on the line for us in Queens, New York. Tamina Eapen from CAMH, and Alexander Caudarella from the U of T, and Yarissa Herman from CAMH as well, also with West End Psychological Services. Thanks to all of you for coming on to TVO tonight. Appreciate it.
Thank you.
Thanks for having us.
Thank you.
Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario, helping businesses stay on the right side of change with strategic thinking, insightful decisions, and business leadership. Are you on the right side of change? Ask an Ontario CPA.